automatic, almost Pavlovian response to the word flu. This is something I've started calling the cultural shrug.
The cultural shrug. I like that. That's a fascinating way to frame it.
Yeah, it's this collective dismissal. You hear flu, and your brain immediately categorizes it. You think, bummer, couple
Yeah.
days on the couch, catch up on that show everyone is talking about, eat some chicken soup and bounce back.
Right. It's an inconvenience.
It's just an inconvenience. We treat it like a rite of passage for winter. It's just a bad cold with a PR agent.
Yeah.
It's annoying, but it's not scary.
That is a dangerously accurate description of how the general public perceives it. We really do minimize it. We use the word so loosely, so casually.
Oh, all the time.
You have a stomachache after some bad sushi. You call it the stomach flu. You have the sniffles and a scratchy throat. You say you're fighting off the flu. But when you look at the actual clinical data, the source material you sent over for this deep dive, that shrug is actually a massive, and potentially fatal, blind spot.
It's not just a blind spot. It feels like a delusion. And I want to start right there with the numbers. Because when I actually sat down and read the clinical data in this file, that whole bad cold image just evaporated. There's one sentence in the source material that stopped me cold. It's a direct quote. More people die of influenza than of any other vaccine-preventable illness in the United States.
It is a heavy statistic. It really is. And when you really sit with that, more than measles, mumps, tetanus combined, it completely reorients your entire perspective.
It has to.
We have a tool, we have a preventative tool, yet the mortality remains the highest in its class.
And we aren't talking about ancient history or, data from the 1918 pandemic. We are talking about right now in the modern era of medicine. The numbers in the report are just staggering. The source estimates between 25 to 50 million cases a year.
In the United States alone.
In the U.S. alone. That's a significant percentage of the population getting sick every single year.
A huge percentage.
And it's not just people feeling crummy at home, right? The hospitalization numbers were, what was it, around 200,000 people are hospitalized annually?
200,000. And tragically, more than 30,000 deaths every single year. It's a consistent toll.
30,000 deaths.
Put that in perspective. Imagine a small city or a fully packed Major League Baseball stadium. Now imagine that entire crowd just wiped off the map. That is the annual toll of influenza in the U.S.
That imagery is.
Yeah.
It's terrifying. So, okay, the mission for this deep dive is pretty clear. I want to dismantle the cultural shrug.
I'm with you.
I want to move past the generic, wash your hands and cover your mouth, advice we've all heard 1,000 times, and actually decode the mechanics of this thing. I want to understand why it hits so much harder than a cold, the weird nuances of the vaccines that I definitely didn't know about, and this very specific, high-stakes window of opportunity for treatment that seems to make or break the outcome.
We are going to unmask the virus. The source material we have today is a comprehensive medical chapter on infectious diseases. So we're going to be able to go from the molecular level right up to public health strategy.
Perfect. Let's start with the invasion then, the invisible phase. How does it actually get from person A to person B? Because I think we all have that cartoon image of someone sneezing directly into another person's face on the subway. Is it always that obvious?
Well, the sneezing person, the aerosol generator, as we might call them clinically, is the classic vector, yes. The primary route of transmission is the inhalation of respiratory droplets.
So it's airborne.
It is. When an infected person coughs or sneezes, they are launching a ballistic spray of microscopic droplets.
Ballistic spray. That sounds like a weapon.
In a biological sense, it is. These droplets are carrying the viral payload. If you're in the line of fire, which is usually within a few feet, you inhale them. The droplets land on the mucosal surfaces of your nose or your throat, and the virus hijacks your cells to start replicating. It's an incredibly efficient system.
Okay, so that's the physics of it. That makes sense. But here is the part in the reading that genuinely spooked me. I'm calling it the silent spreader reality.
Ah, yes. The window of infectivity. This is the key.
The text says adults are infectious from the day before their symptoms begin.
That is the crucial aha moment for understanding why these outbreaks are so difficult, almost impossible to contain.
Think about the implications of that. Let's just play this out. Let's say I have a friend, Bob. Bob feels perfectly healthy. He wakes up, goes to the gym, goes to work. He sits in a conference room with 10 people for an hour, maybe grabs coffee with me.
And he feels fine.
He feels totally fine. I feel safe. But biologically, Bob is already a weapon. He is shedding the virus before he even knows he's in the fight.
Precisely. It's stealth transmission. By the time Bob wakes up the next morning feeling feverish and decides to do the responsible thing and stay home, the damage is already done. He may have already infected his entire office pod, his gym partner, and you.
That feels incredibly unfair.
Yeah.
I mean, it's like the virus has evolved a Trojan horse mechanism. It gets inside the city walls before anyone even sounds the alarm.
It's an absolutely perfect analogy. So once the symptoms actually hit and I know I'm sick, how long does that danger zone last? How long am I a walking biohazard?
For most healthy adults, the rule of thumb is about 7 days. You are infectious from that 1 day prior to symptoms all the way through 7 days after the onset of illness.
So a total of about 8 days.
Roughly an 8-day window of being a public health risk, yes.
Mm-hmm.
Okay, a week or so. I can wrap my head around that. That seems, I don't know, standard for a virus. But the documents mention that the rules are completely different for kids.
They are. And this is why schools and daycares are such efficient engines for community spread. Children are, for lack of a better term, viral factories. They can be infectious for longer than 10 days after the onset of illness.
More than 10 days, so a week and a half, maybe 2 weeks.
Easily. Their immune systems are still developing, so they handle the clearance of the virus differently. They just shed it for a much longer duration. You might send a kid back to school because their fever broke and they seem fine.
But they're still contagious.
They might still be shedding virus and infecting their classmates, which explains why once one kid in the class gets it, the whole grade level just goes down like dominoes.
It's a chain reaction.
Exactly. And there's a third category we need to highlight, which is often overlooked.
Yeah.
The immunocompromised. These are individuals whose immune systems aren't functioning at full capacity, maybe due to chemotherapy, an autoimmune disorder, HIV, or other conditions.
Right. What does the timeline look like for them?
It creates a very, very difficult situation. For them, viral shedding can persist for weeks or even months.
Months. You're saying someone could be contagious with the flu for months.
It's possible, yes. Because their body can't clear the virus efficiently, they can continue to shed viral particles and remain a source of transmission for a very, very long time. It's not their fault at all. It's just that their biological cleanup crew is understaffed.
That really changes the calculus of staying home until you feel better.
Yeah.
You might feel fine, but if you fall into one of these categories, the story isn't over.
Yeah.
Now let's talk about the countdown. From the moment I inhale those droplets from Bob at the coffee shop to the moment I feel like I've been hit by a truck, how much time do I have?
That is the incubation period. And for influenza, it is remarkably short. The range is from 1 to 7 days, but the average is just 2 days.
2 days. Wow, that is incredibly fast.
It is a very rapid turnaround. If you compare it to something like, say, measles or chickenpox or even hepatitis, which can incubate for weeks, influenza is a sprinter.
So the host reaction is almost immediate.
It is. You get exposed on a Tuesday morning commute, the virus replicates like mad, and by Thursday dinner, you are symptomatic. There's very little lag time.
And when those symptoms hit, that's really the defining difference between a common cold and the flu, isn't it?
Mm-hmm.
The sheer velocity of the crash.
Exactly. This is the most reliable way to distinguish them clinically without a lab test. The defining characteristic of influenza is rapid onset.
A cold is a creeper.
Yeah.
That sort of sneaks up on you.
Right. A cold creeps. On Monday, you have a little tickle in your throat. You ignore it. Tuesday, you're sneezing a bit. Wednesday, you have a runny nose and you're searching for tissues. It's a gradual decline.
But the flu?
Influenza is an ambush. You feel perfectly fine at 9 a.m. You're productive, you're happy. By noon, you feel a little off. By 2:00 p.m., you are shivering, your body aches, and you can barely lift your head off the desk. It hits you all at once.
It's the difference between tripping on a crack in the sidewalk and falling off a cliff.
That's a vivid analogy, but it's very accurate. The classic symptom cluster hits hard and fast. Fever, myalgia, headache, malaise, a non-productive cough, sore throat, and rhinitis.
I want to pause on 2 of those words, myalgia and malaise. These are clinical terms, and doctors use them all the time.
Yeah.
But the actual experience of them is so visceral. Myalgia isn't just soreness.
No, not at all. Myalgia is deep, profound muscle pain. It feels like you've run a marathon you didn't train for or like you've been physically beaten up. It's the result of inflammatory signals firing in your muscle tissue. Every part of you aches.
And malaise. Malaise is such a polite, soft word. It sounds like a French dessert or something. But it actually stands for feeling absolutely fundamentally terrible.
It does. It describes a profound systemic sense of unease and illness. It's not just being tired, it's a feeling that your entire body is fundamentally wrong. It's that deep desire to not move, not think, just exist horizontally.
Horizontal is the only way. Now, I found the pediatric section of the source material fascinating because, I have kids, and I have definitely used the phrase stomach flu when they're sick and vomiting. But the source material is pretty strict about this distinction.
Yes, this is a major point of confusion for almost everyone. Stomach flu is a colloquialism. It's a misnomer. Usually when people say that, they're talking about gastroenteritis, a completely different viral issue affecting the gut, something like norovirus or rotavirus that has nothing to do with influenza.
But there is a but here, isn't there? A little bit of gray area.
There is a nuance, yes. Actual influenza, the respiratory virus we are discussing, can present differently in children. While adults mostly get the classic respiratory symptoms, the cough, the congestion, the AIDS kids often report nausea, vomiting, and otitis media.
Otitis media?
Ear infections. It's
Yeah.
very commonly reported in children with the flu, but it's quite rare in adults. The inflammation in the nose and throat can block the eustachian tubes, fluid builds up, and you get a secondary ear infection.
So while stomach flu is technically the wrong term, influenza can cause tummy trouble in kids.
Precisely. So if I'm an adult and I'm vomiting, I probably shouldn't blame the flu.
Statistically, it's unlikely. If you're an adult with significant vomiting, it's more likely to be something else entirely. But if your child has a high fever and is throwing up, influenza should definitely be on the list of possibilities.
Yeah.
That's a really important distinction. Okay, so I got the fever, my body feels like it's been put through a meat grinder, and I'm horizontal in bed. How long does this acute misery last?
The acute phase, so the high fever, the severe aches, the worst of it, usually resolves in about 3 to 7 days.
It doesn't sound too bad in the grand scheme of things. A lost week from work?
Well, if that were the end of it, sure. But there's a long tail to the flu that most people underestimate. The cough and that profound sense of malaise we talked about, that can hang around for more than 2 weeks.
2 weeks.
Easily. This is why people try to go back to work after day 5, because the fever is gone. They show up, they sit at their computer, and they realize by 11:00 a.m. that they have hit a brick wall. They just don't have the energy. The body is still repairing all the battle damage.
It's the hangover that just won't go away. But, unfortunately, feeling like garbage for 2 weeks is actually the best case scenario, isn't it? The source material goes into a pretty scary list of complications that explains that death toll we talked about earlier.
That is where the stakes get incredibly high. We aren't just talking about a bad week in bed. The virus can strip your defenses and lead to much more serious problems. One of the most dangerous is primary viral pneumonia.
And what is that exactly? How is that different from regular pneumonia?
That's where the influenza virus itself, not a secondary bacteria, directly attacks the lower respiratory tract. It invades the lungs, causing massive inflammation and filling the tiny air sacs with fluid. It makes it incredibly difficult to breathe. It can be devastatingly rapid.
And then there's the double tap, the secondary infection.
Secondary bacterial pneumonia. This is a classic 1-2 punch. The flu virus comes in first, and it damages the lining of your respiratory tract. It literally kills the cells that usually sweep out bacteria. It weakens your immune system.
It leaves the doors wide open.
Exactly. And then common bacteria like staphylococcus or streptococcus that might be hanging around harmlessly in your nose and throat take advantage of that open door. They invade the damaged lung tissue and set up shop in the wreckage. That bacterial pneumonia can be lethal.
And it's not just the lungs. I was really surprised to see heart inflammation on the list of complications.
Yes. Myocarditis, which is inflammation of the heart muscle itself, and pericarditis, which is inflammation of the lining around the heart. The virus can become systemic. It doesn't always stay confined to the nose and throat.
So it can get into the bloodstream and attack other organs.
It can. We also see rare but severe complications like encephalopathy, which affects the brain transverse myelitis, myositis, and Race syndrome, particularly in children who are given aspirin.
It's a full-body assault.
It really is, and we have to emphasize this. For the elderly or the immunocompromised, getting just the flu is like kicking the supports out from under a building. It triggers a cascade.
What do you mean by a cascade?
Well, let's say you have an elderly patient with underlying heart failure. The stress of the flu, the high fever, the increased metabolic demand can decompensate their condition. Their heart just can't keep up.
So the flu pushes their chronic condition over the edge.
Exactly. If you have diabetes, the infection destabilizes your blood sugar control. If you have COPD, it causes a severe exacerbation. It worsens every underlying comorbidity. That's why so many of the deaths aren't officially listed as flu deaths. They're listed as heart attacks or kidney failure or organ failure that was triggered by the flu.
So knowing the enemy is this formidable, that it's a shapeshifter, a stealth spreader, and a potential killer, Let's talk about our defense, the shield. The source is absolutely unequivocal about this. Vaccination is the #1 tool.
Without question, it is the best, most effective means we have available to decrease morbidity and mortality. It's the cornerstone of prevention.
And the target audience isn't just sick people or old people. I feel like a lot of younger, healthy people often skip it because they think, I'm tough, I'll survive it if I get it.
That is a fundamental mistake. The guidance is incredibly broad for a reason. Annual vaccination is recommended for all persons aged 6 months or older. That is the baseline. If you breathe, you should probably get the shot.
But there's a specific nuance here for caregivers that I loved. The concept of cocooning. Can you explain that?
This is a beautiful, almost poetic concept in public health. Think about a newborn baby. Infants under 6 months old cannot be vaccinated. Their immune systems are not mature enough to handle the vaccine's instructions yet.
So they are complete sitting ducks for the virus.
Totally vulnerable, unless you build a cocoon around them. You vaccinate the people around the baby, parents, older siblings, daycare workers, babysitters, grandparents. Anyone who enters the orbit of that infant needs to be vaccinated.
So you're building a wall?
You're building a wall of immunity around the vulnerable host so the virus physically cannot get close enough to strike. It's a selfless act, really.
It's herd immunity on a micro scale, protecting the ones who can't protect themselves. Now, let's talk timing. I'm guilty of this. I usually procrastinate and get my shot whenever I happen to walk past a pharmacy sign in, I don't know, December or January. But the source says I'm doing it wrong.
You are late to the party. The ideal window is October or November.
Why specifically then? Why not get it out of the way early, like in September or even August?
It's all about timing the peak. You want to allow your immunity to develop before the peak of the influenza season, which in the U.S. is typically deep winter, January, February. It takes about 2 weeks for your body to fully recognize the vaccine and build up those antibody titers, your defensive soldiers.
And if I get it too early, like say in August?
The immunity can wane over time. It's not permanent. By the time the virus actually shows up in February, your antibody levels might have dropped too low to be fully protective. So October and November is really the Goldilocks zone.
Not too early, not too late.
Exactly. But if you wait until everyone around you is coughing in January, you're basically trying to build the roof while it's already raining. You might get it up in time, but you might also get soaked.
Okay, let's unpack the menu of vaccines. Because I honestly didn't realize there were such distinct categories with such different rules.
Yeah.
We have the shot and we have the spray, TIV and LAIV.
Right. And these aren't just different delivery methods. They are biologically different tools. Let's start with TIV, the trivalent or quadrivalent influenza vaccine. This is the traditional shot.
The arm poke.
The arm poke. The key thing to understand here is that it uses an inactivated virus. It's a killed virus, which means it is biologically impossible for the TIV shot to give you the flu. The virus is dead. It has been dismantled. It cannot replicate. That is a myth we need to dispel right now, definitively.
But, and I'm playing devil's advocate here because I hear this constantly. People swear they get sick after the shot. I got the shot on Tuesday and I felt terrible on Wednesday. What's happening there?
The source explains this perfectly. The most frequent adverse effect is just soreness at the injection site. However, TIV can cause a low-grade fever and malaise in some people. Why?
It's your immune system working.
It's your immune system doing a fire drill. Your body sees the dead virus parts, thinks it's a real invasion, and revs up the immune system. It raises your body temperature. It activates white blood cells. That feeling of being a bit run down is actually your immune system learning and preparing. It is an immune response, not the influenza infection.
That's a great way to put it. So who gets the TIV?
Basically, everyone over 6 months old, regardless of their immune status. Because the virus is dead, it's safe for immunocompromised people, pregnant women, everyone. There are even high-dose versions specifically for adults over 65 because as we age, our immune system gets a bit sleepy and needs a louder wake-up call to generate a strong response.
Okay, then we have the LAIV, the live attenuated influenza vaccine. This is the nose spray.
This one is fascinating. It uses a live but weakened virus. It's attenuated, which means it's been hobbled so it can't cause severe disease in a healthy person.
So it's a sparring partner, not a real opponent.
A very weak sparring partner, yes. And because it's a live virus entering through the nose, it mimics a natural infection much more closely than a shot in the arm.
So it creates a more realistic rehearsal for the body.
Exactly. It can induce a broader mucosal immune response right there in the nose and throat, which is the portal of entry for the real virus. It trains the guards right at the gate.
No needles sounds great, But the list of people who can't have this one is surprisingly long.
It is. It's approved for healthy people aged 2 to 49. But you have to notice the emphasis on healthy. You cannot give this to immunocompromised people.
Because even a hobbled virus could still cause trouble for them.
Correct. Their defenses are too low to handle even a weakened opponent. You also don't give it to pregnant women. And here is a surprising one. It is not for kids under 5 who have a history of asthma.
That seems really counterintuitive. I would have thought you'd want to spare an asthmatic kid a needle to avoid the stress of a shot.
You would think so, but the data tells a different story. Studies showed an increase in reactive airway disease. So, wheezing in that specific group after they received the spray. The local irritation from the live virus in the nasal passages seems to be enough to trigger their asthma.
So for them, the shot is actually safer.
Much safer. That is a crucial detail for parents to know.
Now, speaking of safety and myths, we have to talk about the egg allergy thing. I feel like for years, the rule was if you're allergic to eggs, no flu shot for you. It was just this golden rule. But the source material says that's largely history.
It's an outdated precaution for the most part. Most flu vaccines are grown in eggs, so there are trace amounts of egg protein. But the expert clarification here is that an egg allergy is not an automatic no.
So if I break out in hives when I eat an omelet, I can still get the flu shot.
Yes. The current recommendation is that you can receive the TFZ, the shot, not the spray, and then just be observed for 30 minutes by a healthcare provider afterward, just to be safe.
Okay. And what if it's a severe allergy, like anaphylaxis, throat closing up, needs an EpiPen territory?
Even then, it's not a hard no. You aren't just turned away. The guidance is to refer you to a specialist, a physician with expertise in managing allergic reactions, like an allergist. They can often still administer the vaccine safely in a controlled environment where they can respond to any reaction.
So the risk of the flu is considered high enough that we really try to find a way to vaccinate almost everyone.
We do. The only strict do not pass go contraindication is if you have had a severe allergic reaction to the vaccine itself in the past.
That's a huge shift in perspective. There's one other warning label I saw in the source regarding something called Guillain-Barré syndrome.
Yes, GBS. This is a rare disorder where the body's immune system mistakenly attacks your nerves, which can lead to weakness or even paralysis. The precaution is that you should avoid vaccination if you are not at high risk for flu complications and you experienced GBS within 6 weeks of a prior flu shot. It's a very specific exclusion, but an important medical history question for providers to ask.
Okay, so we've covered prevention, we've built the cocoon, we've timed our shot, but let's say the invisible invader got through.
Yeah.
I'm sick. I'm 2 days in. This brings us to the arsenal and what the outline calls the 48-hour window.
This is perhaps the most critical concept in influenza treatment. The golden rule is that antiviral drugs are most effective if they are started within 48 hours of symptom onset.
Ideally even sooner, right? The source mentioned something about 12 hours.
Ideally within 12 hours, yes. The sooner you can get in there and stop the virus from replicating, the better the outcome will be.
Now, I have to ask the cynical question here. The source says taking these drugs reduces the duration of illness by approximately 1 day. So I pay for a doctor's visit, I pay for the prescription, I risk side effects, all to feel better on Tuesday instead of Wednesday. Is it really worth it?
That is a very fair question if you look at it solely through the lens of your own personal comfort. If you're a healthy 30-year-old, saving 24 hours of misery might not seem like a huge win. But the goals of therapy are much broader than just your comfort.
How so? What are the other goals?
It's not just about one less day of feeling bad. It's about preventing those severe complications we talked about earlier, the pneumonia, the hospitalizations. If we can stop the viral load from peaking, we might save your lungs from damage. It's about reducing your viral load so you are less likely to infect your elderly parent or your young child.
And on a societal level.
On a societal level, it's about reducing absenteeism from work and school. It's a public health tool as much as it is a personal one. You're taking the drugs to stop the fire from spreading to the rest of the house and to the neighbors.
That's a much more compelling argument. So let's look at the drugs themselves. The source breaks them into the winners and the losers.
Yeah.
The winners seem to be the neuraminidase inhibitors.
That's a mouthful, isn't it?
It sounds like a sci-fi villain.
We usually just refer to them by their generic names. Also Tamiflu, which most people know by the brand name Tamiflu, and Zanamivir. These are the current heavy hitters. They are active against both influenza A and influenza B.
And then we have the losers, the adamantanes, amantadine and rimantadine. The story here is actually a fascinating and kind of scary lesson in evolution.
It is evolution happening in real time. These drugs used to be the standard. They worked quite well. They were the go-to prescription for years, but the virus mutated.
So it outsmarted the drug.
It did. The source notes that the CDC no longer recommends these at all because of the rapid emergence of widespread resistance. The adamantanes worked by blocking a specific channel in the virus, the M2 ion channel, which the virus needs to uncode itself inside your cells. But the virus just changed the shape of that channel. It evolved around the blockade.
So current flu strains just laugh at these drugs.
Essentially, yes. They are useless for the strains circulating now. It's a stark reminder that we're in an arms race with a biological entity that is constantly adapting to our weapons. The virus is not static. It is constantly trying to solve the puzzle of how to survive our drugs.
So if you have an old bottle of amantadine in the back of your medicine cabinet from a decade ago, throw it out. It's useless.
Completely useless against the current flu. It's like trying to use a key for a lock that has been changed.
Now back to the winners, the neuraminidase inhibitors. Are there risks? Because I saw a specific warning for kids taking oseltamivir or Tamiflu that looked a bit alarming.
You are referring to the reports of neuropsychiatric events. Yes, there have been post-marketing reports of delirium, seizures, hallucinations, and even self-injury in pediatric patients taking oseltamivir.
That sounds terrifying. Here's a drug for your cough, by the way. Your child might start hallucinating.
It is very concerning, although it is considered rare. We don't know for sure if it's the drug itself or the high fever from the flu causing these issues. Influenza itself can cause delirium in children, but the correlation is there in the reports.
So it's a be aware situation for parents.
Absolutely. It's something parents need to be aware of. If you give your child Tamiflu, you need to monitor them closely for any unusual behavioral changes.
What about pregnancy? We said earlier the flu is dangerous for pregnant women, but are the drugs safe?
This is always a difficult area in medicine because we rarely do large-scale clinical trials on pregnant women for obvious ethical reasons. We don't want to risk the fetus. The source uses the very careful phrasing, solid clinical safety data are lacking.
It's not very reassuring.
It sounds vague, I know. However, because the risk of severe influenza itself is so high for pregnant women, they are at a very high risk for hospitalization and severe respiratory distress. The general consensus is that the benefits of the neuraminidase inhibitors usually outweigh the theoretical risks.
So it's a risk-benefit calculation, and the flu is the bigger, more immediate risk.
Correct, but the adamantanes, definitely not. Those are known to be teratogenic. They can cause birth defects. So those are strictly off the table during pregnancy.
Okay. And for those of us who maybe missed that 48-hour window or just want to tough it out at home, what does the source recommend for supportive care?
It goes back to the basics that your grandmother probably taught you. Supportive care, adequate sleep, maintaining a low level of activity. Don't try to work from bed. Don't try to clean the house. Your body needs every single ounce of energy for the immune fight.
Low level of activity. I'm going to use that excuse next time. Sorry, doctor's orders, low level of activity.
Fluids are absolutely crucial to prevent dehydration from the fever. Warm tea or soup can help with the mucosal clearing. Lozenges for the sore throat. And most importantly, the stay-home mandate. You need to rest for your own recovery, but you also have a civic duty to stop the chain of transmission.
There's one last category in our deep dive that I hadn't really considered before. Prophylaxis. This is basically taking the treatment drugs to prevent getting sick in the first place, right?
Correct. It's using antivirals as a shield before the infection can take hold. The clinical term is chemoprophylaxis.
Who is this for? Is this for me if I just don't want to get sick before a big vacation? Hey, doc, give me some Tamiflu. I'm going to Hawaii next week.
Generally, no. We don't hand these out like candy because, again, we don't want to breed more resistance in the virus population. It's reserved for very specific high-risk situations. For example, high-risk people who biologically cannot be vaccinated for some reason, or unvaccinated people who are living with someone who is very high risk.
The source mentioned nursing homes specifically. That seems like a critical application.
That is a key use case. Imagine you have a long-term care facility and an outbreak starts. 2 residents test positive. You might give prophylaxis to all the residents in that facility, regardless of whether they got the vaccine.
Wait, even if they already got the shot, why?
Yes. Because remember, in the elderly, the immune response to the vaccine might be weak or incomplete. Their body might not have built up enough antibodies. The vaccine isn't 100% effective. So during an ongoing outbreak in a closed facility, You add the chemical shield of antivirals on top of the biological shield of the vaccine.
It's an emergency brake.
It's an emergency brake. It's a belt and suspenders approach for a very vulnerable population.
But there is a logic puzzle here if you mix the drugs and the vaccines, specifically the live spray vaccine.
Right. This is where it gets a little tricky. You have to think about the mechanism again. The spray, the LAIV, contains a live weakened virus. The antiviral drugs are designed to kill the influenza virus.
I see where this is going.
If you take them at the same time, the drugs will just kill the vaccine virus before your body has a chance to learn from it and build immunity.
So you're canceling out your own protection. You're shooting your own soldiers before they can even finish boot camp.
Exactly. So the rule is you have to wait 48 hours after stopping the antiviral drugs to get the spray vaccine. Or if you got the spray first, you have to wait 2 full weeks before you can take the drugs.
It's a timing puzzle you have to get right, or you just waste the dose.
It is. Timing is absolutely everything with influenza, from vaccination to treatment.
So we've covered a massive amount of ground here. We've gone from the invisible transmission phase, where you're spreading it without even knowing, to the sudden, truck-hitting impact of the symptoms. We've looked at the detailed menu of vaccines, the spray versus the shot, and that critical 48-hour clock for treatment.
And I think the big takeaway for me, connecting all this to the bigger picture, is that the flu isn't static. It's not a fixed enemy like a broken bone or a cavity that we've figured out how to treat.
Right. The whole story with the adamantane drugs proves that in a big way.
It does. The virus evolves, and our tools have to evolve with it. The vaccine formulation changes every single year based on what we call antigenic drift. Scientists are constantly trying to predict the virus's next move, trying to guess which disguise it will wear next winter.
It's a never-ending chess match.
It really is. And in many ways, we are always playing catch-up.
Before we sign off, there was one final detail in the source notes that I found surprisingly philosophical. It was about testing.
Ah, yes.
The gold standard.
The source says that while we have rapid tests, those quick swabs you get at the urgent care that give you an answer in 15 minutes, the gold standard for diagnosis is still viral culture, actually growing the virus in a lab.
That is true. The rapid tests are great for speed, but they aren't perfect. They can have false negatives. The absolute truth, identifying exactly what the virus is, what specific strain it is, that requires time. It requires biology to do its work in a petri dish.
And I just love that. In an age of instant gratification where we want to know, do I have it, yes or no, in 5 minutes, the most accurate truth still takes time to grow. A profound thought to end on. Science cannot always be rushed. Sometimes you have to wait for the answer.
So, to our listener, respect the virus, respect the timeline, and maybe don't wait until January to get that shot.
Ideally, October or November. Don't procrastinate.
Thanks for diving in with us today. This was incredibly insightful.
My pleasure. A very important topic.
We'll catch you on the next deep dive.